Good afternoon, ladies and gentlemen. Our webinar is going to begin. I'm Steve Love, President and CEO of the Dallas-Fort Worth Hospital Council. We want to thank you for joining us today for this educational webinar. It's hosted in coordination with Adaptive Workforce Solutions, and they're an associate member of the DFW Hospital Council. Our topic today: Beyond Headcount, Strategic Workforce Models for Hospitals that are Navigating the Post-One Big Beautiful Bill Act era. And we're going to be detailing some of the changes that will occur with the passage of the One Big Beautiful Bill Act. We're going to cover some of the implications for workforce planning and how hospitals can deploy alternative labor models to maintain service, but also navigating the funding of their operations. Today, we're very happy to have with us an excellent speaker, Julie O'Keefe, who is President and CEO of Adaptive Workforce Solutions. Her company was founded in 2017 and is staffed with healthcare experts who provide a wide range of workforce management solutions, and they are helping hospitals nationwide to reduce cost, but also improve outcomes. One administrative item before we begin: we will be glad to take your questions, but please type them into the question box, and at the end of Julie's presentation, she'll answer those. So we're real excited about this webinar, and we look forward to hearing Julie. And with that, I'm going to turn it over to Julie O'Keefe.
Can everyone else see it okay? Well, thank you all. I appreciate your time today, and I appreciate Steve and Chris allowing me to speak with everybody today. As Steve had mentioned, I'm Julie O'Keefe. I'm the CEO of Adaptive Workforce Solutions. We're going to go over some of the key provisions in the One Big Beautiful Bill. And particularly my experience has been on the workforce management side of the healthcare industry, particularly contract labor. So I'm going to keep it mostly to my lane, but I'm going to go over some of the key provisions that are in the bill, particularly how it's going to affect Texas and how it will affect our healthcare workforce. And then I'll dive into some areas about the healthcare staffing industry directly, and then hopefully share some saving strategies that you might be able to implement within your own healthcare organizations. So with that said, as most of you already know, the OBB introduced a broad overhaul of Medicaid policy and funding structures. This slide provides a high-level summary of the provisions most relevant to hospitals and health systems. I won't go into detail here, but let's quickly touch on a few key points. Some of the headline provisions will work like work requirements and frequent eligibility checks will have limited operational impact here in Texas, where Medicaid eligibility and enrollment processes are already quite restrictive. Where Medicaid, we'll have, so those impacts will have very little operational impact here in Texas. Where Medicaid eligibility checks will have, and enrollment processes are already quite restrictive. Others, however, hit much closer to home. The bill caps state direct payments and freezes provider state or tax rates, two of the primary tools Texas has relied on to supplement its limited Medicaid program. That's especially concerning for rural and safety net hospitals in our non-expansion environment. The bill does include a $50 billion in rural health funding, but it's competitive, time-limited, and unlikely to fully offset the losses we're facing. For many rural facilities, it's a partial solution, not a replacement. We're also watching the new immigrant eligibility restrictions closely. In a state like Texas, where a large immigrant population, we're likely to see an increase in uncompensated care, especially in emergency settings. And while it's not shown on this slide, the bill includes two other important changes. First, a late-stage FMAP reduction that lowers the federal match rate for certain Medicaid services, meaning Texas may receive less federal funding for care it's still expected to provide. Second, a rollback of enhanced ACA subsidiaries. That change could significantly impact marketplace coverage, affordability in rural Texas, where ACA enrollment has been especially tight. We'll talk more about this in a few minutes. Let's take a little bit closer look at how the OBB is expected to impact Texas specifically. First, Texas hospitals face disproportionate financial risk. Nearly 1.7 million Texans are projected to lose health insurance coverage under the new eligibility restrictions and subsidy changes, adding pressure to a system that already has the highest uninsured rate in the country. At the same time, Texas has expected to lose roughly 8% of its federal Medicaid funding, which only deepens the fiscal strain on hospitals already operating within thin margins. What happens when people lose coverage? They often turn to emergency departments for care, especially when they have no other point of access. That leads to rising ED volumes, higher uncompensated care, and increased stress on critical staffing, especially for hospitals already struggling to recruit and retrain talent. Finally, it is our rural and safety net providers who are likely to feel this most acutely. Texas already leads the nation in rural hospital closures. Many of the remaining rural facilities and large urban safety net systems depend on the very funding mechanisms that the OBB has just restricted. These changes could accelerate service reductions, workforce cuts, or even shutdowns in areas where the community has fewer alternatives for care. So while the headline numbers are significant, the rippled effects on operations, staffing, and access to care may be more consequential. And that's what we're here to talk about today. What's it going to take to protect patients and financial stability in the post-OBBB era? This slide summarizes projected 2029 Medicaid losses due to OBB using data from George Washington University. As you can see, the national picture is grim. Nearly $96 billion in lost federal funding, almost 1 million in jobs at risk, and a substantial hit to GDP and tax revenues across states. For Texas specifically, the forecast shows almost $3 billion loss in federal Medicaid funding, a hit to Texas GDP of nearly $4.8 billion, and about 44,000 jobs lost, including over 20,000 in direct healthcare roles. That's the fourth highest job loss total in the country. As rural hospitals close or shift to outpatient models, demand for inpatient RNs, hospitals, the acute care staff may decline in these areas. Staffing firms dependent on rural inpatient placements, especially travel nurse and locum tenens roles, may face volume declines. As patients travel farther for care, remaining hospitals, often larger regional centers, see higher patient loads, which can spike staffing needs in those hubs, resulting in increased demand for contingent labor to meet increased patient volumes. Meanwhile, the shift to outpatient care is driving demand for ambulatory, home-based, and virtual clinicians. Staffing firms that adjust to meet evolving care delivery models can explore new avenues for labor deployment, including recruitment that prioritizes advanced practice providers, behavioral health, physical therapy, and other telehealth-ready roles. This map highlights a lesser known but critical piece of the coverage story in Texas. Rural counties rely heavily on the ACA marketplace plans, particularly in South and West Texas. In non-expansion states like Texas, the ACA fills gaps for low-income adults who otherwise would be eligible for Medicaid in expansion states. About 2.5 million of the nearly 4 million Texans enrolled in the ACA in 2025 fall between 100% and 150% of the federal poverty level. That reliance is geographically concentrated to 40 counties, had more than 15% of residents enrolled in that marketplace in 2024. The OBB's funding changes threaten this fragile ecosystem. Texas is projected to lose $1.2 billion in Medicaid support, but a last-minute rural health fund could offset some of that loss, an estimated $1.6 billion over 5 years. According to Texas Hospital Association, they have acknowledged that this could have been a much worse outcome. So what is the impact it has on our healthcare workforce? Changes to the federal support for medical student loans, potential impact on international medical graduates, and other provisions may worsen difficulties and steepen the upcoming retirement cliff. Maintaining the right workforce for future needs will require more than hiring incentives, provides needs to optimize workflows and ensure clinicians are equipped to practice at the top of their license and ideally at the top of their competency to maximize the impact of care. The OBB also imposes significant administrative burdens. Compliance with new Medicaid work requirements, 80 hours a month, eligibility redeterminations, and system updates will require new IT infrastructure, staff retraining, and more intensive oversight, diverting resources from direct patient care. Administrators must also plan for heightened numbers of patients, reduced reimbursement rates, and the uncertainty in federal state Medicaid matching, all of which contribute to instability for hospitals. These pressures increase the risk of service reductions or even hospital closures with long-term implications for community health access and care quality. The impact of Medicare Advantage. While OBB doesn't directly change Medicare Advantage MA policy, it does reduce other funding streams hospitals have historically relied on to absorb losses, making the financial impact of MA plans more acute. Medicare Advantage now covers over 33 million Americans, and its cost containment strategies, especially the expanded use of observation stays, are drawing increased scrutiny. By avoiding inpatient classification, MA plans reimburse hospitals at lower rates. That contributes to higher levels of uncompensated care, especially in rural and safety net settings. In 2019, observation stays for MA beneficiaries were already 28.6% longer for patients on traditional Medicare. By 2024, that gap has widened by nearly 37%. The OBB cutting Medicaid directed payments and supplemental support hospitals have fewer resources to offset these reimbursement shortfalls, worsening already tight margins. One of the lesser discussed consequences of the OBB is the ripple effect of its Medicaid and SNAP funding cuts on state employment. According to a 2025 analysis by George Washington University, these cuts are projected to cost Texans more than 62,000 jobs by 2029, among the highest in the country. While some states face a higher percentage of job loss, Texas is hit harder in absolute numbers due to the size of its population and the scope of its Medicaid and SNAP programs. Many of these job losses are expected in healthcare, social services, and adjacent sectors, amplifying workforce shortages and weakening local economies, especially again in the rural communities. So even if your hospital isn't directly impacted by SNAP policy, the broader ecosystem is that it translates into increased pressure on emergency departments, reduced local tax bases, and a tighter labor pool. Registered nurse employment across U.S. The shrinking U.S. labor force driven by aging demographics, declining male participation, and slowing population growth signals a structurally tight labor market. Competition to source and retain clinicians will intensify, pushing up pay and bill rates and pressuring margins. As labor tightens, the role of healthcare staffing firms become more critical, but also more complex. Healthcare roles, especially those requiring licensure and technical training, will be disproportionately affected due to high demand and burnout-driven attrition. Differentiation through technology, candidate experience, and upskilling programs will be essential for long-term resilience. Texas ranks second in the nation for total RN employment, with more than 260,000 registered nurses working across the state. But high numbers don't tell the whole story. Demand continues to exceed supply in many regions, especially rural and border areas. Texas hospitals face additional pressures from population growth, aging demographics, and reduced Medicaid resources under the OBBB. Most RNs work in hospitals, but a growing share are moving to outpatient, home health, and gig worker-based roles. That shift requires more flexible staffing models. Sustaining this workforce will require better retention strategies, scalable onboarding, and smarter use of contingent labor, not just recruiting more nurses. Critical occupational shortage areas and skill gaps. The healthcare and social assistance sector is projected to add 2.3 million jobs between 2023 and 2033, according to the Bureau of Labor Statistics. More than 1/3 of all new U.S. jobs in that period. Many of the fastest growing occupations like nurse practitioners, physician assistants, and therapy assistants require significant education and training, which means pipeline issues can't be solved quickly. These roles are also among the hardest to staff in rural and underserved communities where shortages are already acute. Hospitals should assess their current workforce mix and projected needs, particularly in high-growth clinical support roles, and explore strategies such as internal float pools, local training partnerships, and expand use of flexible labor models. The data also suggests that workforce planning can't be siloed to just financing HR, clinical leadership, and strategy teams need to work together to balance cost controls with patient care. Areas for strategic response post-OBBB. With OBBB now a law, hospitals must move quickly to understand how Medicaid funding shifts could affect their bottom line, particularly in high Medicaid or non-expansion states. Begin with a financial impact assessment. Quantify likely reimbursement reductions and anticipate increases in uncompensated care. Operational optimization is critical. Assess which service lines are going to be sustainable under the new funding constraints and revisit staffing models accordingly. Regulatory compliance updates may be required, particularly related to eligibility checks, billing, and workforce classification rules. Flexibility in staffing will be key. Cross-training clinical staff to move between inpatient and outpatient care can reduce resilience on high-cost travel labor. Demand management such as virtual care, digital intake, and synchronous visits can improve efficiency and reduce workforce strain. Hospitals should also look beyond their own walls. Community partnerships and shared staffing strategies may unlock new efficiencies. Finally, use data proactively. AI and analytics can also help forecast demand, flag inefficiencies, and identify early signs of service disruption. So let's kind of get into how the OBBB is going to impact the healthcare staffing industry. While long-term travel nurse contracts remain costly, hospitals are increasingly turning to per diem and shorter-term contracts as a more flexible and cost-effective alternative. The locum tenens segment is one of the few consistently growing areas fueled by aging physicians and the need to maintain revenue-producing services. and the expanding roles of nurse practitioners and physician assistants. App-based and gig-style platforms are making it easier to engage clinicians for shorter-term assignments, appealing to those who want flexibility without committing to relocation. Technology continues to reshape the staffing landscape from credentialing to compliance. AI and automation tools are helping hospitals reduce delays and streamline onboarding. While OBBB preserved key tax advantages for staffing firms and travel nurse stipends, which was a win-win, hospitals must still contend with rising labor costs and overhead pressures. As you can see, the SG&G costs, which include recruitment, compliance, and technology, now make up a larger share of the agency bill rate than in prior years. This may reflect ongoing inflation as well as the need to provide more sophisticated staffing operations. As the chart shows, payroll and benefits remain the largest component of travel nurse rates, but increasing costs in non-wage areas can no longer be overlooked when budgeting. So inflation-adjusted travel bill rates remain slightly above pre-pandemic levels. Travel nurse bill rates dropped from $101.57 in 2023 to $88.83 in 2024, reflecting continued normalization post-COVID, but remain slightly above pre-pandemic levels when adjusted with inflation. Wages decreased as a share of the bill rate, but other costs like housing rose from 26.4% to 31.3%, offsetting margin gains for staffing companies. Staffing remains costly, but just with a different cost mix. Importantly, demand pressures persist. The U.S. still faces 200,000 annual nurse openings and a projected physician shortfall of 86,000 by 2036. These gaps mean hospitals will continue to rely on contingent clinicians to maintain access, even as the cost structure evolves. So, while the medium staffing firm saw a steep 41.3% revenue decline in 2024, this reflects an industry-wide normalization rather than isolated underperformance. Even top firms saw significant drops, pointing to systemic contraction after pandemic-era surges. That said, travel nurse revenue and hours remain above pre-pandemic levels. The impact has been more severe for smaller or less diversified firms, while larger providers, staffing firms with nursing allied or locum tenens, have continued to gain greater market share. COVID-era disruption helped larger firms with stronger financial footing, rapidly expanding their market share, reaching a record 39% of the top 5 and 53% for the top 10 in 2024. Continued shortages and high-need clinical roles have kept demand high, especially for firms able to source across multiple specialties and geographies. But the path forward requires balance. Aggressive recruitment must be paired with sustainability. Strategic partnerships and specialty pipeline development will be key differentiators in the tight labor market ahead of us. So that kind of explains the landscape as it relates to the healthcare staffing industry. Let's focus a little bit now more on different types of workforce staffing models and how they can be utilized to maybe encourage some cost savings within your healthcare organizations. And before I dive into each of these core areas, I wanted to give a definition of each for those of you who might not be familiar with these models. Managed service programs, referred to as MSP, are third-party partnerships that manage an organization's contingent workforce. MSPs streamline the entire process from sourcing and onboarding to vendor management and payment, helping reduce costs, ensure compliance, and improve efficiency. Programs may be vendor neutral with multiple agencies competing for orders, or primary vendor-led, where one firm fills most roles and outsources unfilled ones. In 2024, 73.2% of travel nurse revenue was generated through MSP programs. Direct staffing services connects healthcare organizations with individual staffing agencies or a group of agencies. While a viable option for organization with in-house capability to manage multiple vendor relationship, it does increase administrative burden and risk of billing or compliance issues. Employer of record serves as a legal employer for a company's workforce, managing payroll, taxes, benefits, and compliance, while agent of record, or AOR, on the other hand, is used to process payments and manage compliance for 1099 independent contractors such as locums, APs, and nurse practitioners. Both models are useful for organizations operating across jurisdictions or seeking to simplify employment or payment administration. Gig worker on-demand staffing, also known as on-demand staffing, refers to short-term project-based roles often filled via digital platforms. These platforms offer flexibility for both workers and facilities, but lacks the structure and oversight of more traditional staffing models. So with that, let's go ahead and start getting into some of what we've want to talk about today is those strategic staffing models that might be able to be utilized to help hospitals save money. So here we look at employer of record versus agency cost analysis. EOR is a cost-effective alternative to agency contracts. EOR serves services provide payroll, tax, and HR administration for contract staff without assuming recruitment functions. EOR is especially valuable for organizations managing out-of-state hires, float pools, gig workers, or decentralized teams. EOR versus agency contracts, the key differentiators, as you can see here, are based on the hourly rate, you can save anywhere between 15 to 25%. The administrative burden streamlines monthly fees, onboarding costs, cover payroll taxes, as mentioned before, reduces legal exposure, and internal workloads. Sourcing. Since the client sources candidates directly, there are no conversion fees, which can be significant and can be charged as anywhere upwards to 15 to 30% of a candidate's annual salary. This is a significant cost savings. In addition to that, when you're utilizing an EOR service, your turnover is often likely lower due to better alignment with cultural organization goals. So what I brought with me today is a real-world savings with EOR. We worked with this hospital. This is a hospital that we have worked with since 2019, where we implemented Cherokee Nation Health Services, which we've worked with since 2019, to combat rising costs from agency and reduce agency reliance. As you can see here, we looked at the overall spend, which was $22.5 million as part of their MSP program. Their employer of record was $5.4 million, and this was a study that we did in 2023. When you take all of that and you manage that against the hourly rate, that average hourly rate that was saved per hire, it saved the organization almost $770,000 just for that 1 year. Collectively, over the years, Cherokee Nation has saved approximately $3 million just by utilizing employer of record services over the traditional agency staffing model. Where the employer of record in action can come to play is on 90-day trial periods. Now, Cherokee Nation is a very large tribal healthcare organization, and they have very strict hiring policies. And they also have a less staff to process their employees. So being able to put a potential candidate on a 90-day trial period was significant for them. That way they didn't lose the candidate. They were able to go through the process and then convert into a full-time employee with the facility. It was also great for taking people that had been on long-term travel assignments and to start creating in-house travel pools and float pools. Also for retirees, there's a lot of people that retire, but maybe they want to pick up 1 or 2 shifts a month or 3 shifts a month. It's a great opportunity to, again, access retirees that have worked for your organizations, that have a proven track record of performance and skill. So these are some of the areas where you can look at that can save you in employee of record. And also, if you break it down just by like the example that we're showing here with the RN example, you have an RN that, was at this time, the bill rate was about $104.56 per hour for a recruited OR nurse. Through the EOR services, we were able to pay that nurse at $86 and $22 bill rate. And a lot of times too, when we're eliminating that middleman, the nurses are paid more than what they would probably get from an agency. So that's very important to note as well when you're looking at savings. It makes the nurses obviously happy, and it makes the facilities happy because they get the lower bill rate. And if you look at the delta on that, the 1834 times the total hours worked by an average OR nurse, the savings are significant. You're looking at $33,000 just on one nurse. Now times that by 20 nurses, and you can see how those savings really add up. The next thing we want to talk about is gig worker. Although relatively new to the healthcare market, gig worker platforms can reduce overhead costs for healthcare facilities, allowing them to adjust staffing levels to match demand, avoiding expenses associated with full-time staff, such as salaries, benefits, and paid time off. However, careful consideration of potential challenges and a strategic approach to integrating gig workers into the existing workforce are essential for long-term success. It's also important to note that the classification of gig workers, including nurses as employees or independent contractors, is a complex and evolving legal issue for healthcare. Federal and state regulations can influence how platforms classify their workers, impacting who is considered the employee of record and the associated responsibilities of professional liability insurance and benefits. So as there are some benefits to the gig worker model, there's also some things that you need to be concerned about, especially with regards to agency platforms. With agency platforms, which a lot of these agencies, as I had mentioned, the industry is down 41.1%. So agencies now are scrambling to come up with new solutions and new models that are going to replace that revenue that they were losing through those traditional models. And the pendulum swung the other way, right? Now hospitals have a lot more staff. They've been able to recruit staff. They've been able to convert staff. So they have a lot more staff. And now it becomes more about like, what do we do with the staff? How can we maximize the staff? And so gig worker platforms become very advantageous and they become very attractive. Now, when you're looking at these agency models that have the agencies own the platform, the technology platform, remember the draw to a gig worker economy is the hospitals themselves. So you guys are attracting the talent and you want to make sure that your talent and is staying within your community, that they're not being marketed out to other competitors or outside of your community like we saw during the pandemic. So it's very important to make sure that you have an independent gig worker model that is going to secure your workers in your community. Also, you have to be mindset on agencies setting the pay rates versus the facilities setting the pay rates, right? And that the agencies might be taking a larger cut of the earnings. It has been reported by gig workers in some platforms that they feel like the bill rates are much lower than if they were working or going to work in a float pool with a hospital directly. So be mindful of that. I would also look at the fact that, sometimes these companies can change the terms, the pay rates, or the policies without client input. So these are some of the things that you want to be concerned with if you're looking at going to a gig worker platform. Also, as I mentioned, we looked at some of the pros and cons from the perspective of the healthcare worker. Obviously, flexibility is always at the top of their list, and that's important to them. Independence is important to them, where the fact that they can choose where they want to work. Back in the day, in the traditional per diem model, you still had that agency control, which is again why I'm kind of concerned about those agency platforms, making sure that the control is put back into the facilities and to the gig workers themselves. Some, again, should be experiencing higher pay if it's a true transparent gig worker environment. I think the other thing that is on the con side, I think the biggest issue lies in the lack of benefits. The gig worker is, increasingly impacting healthcare, offering flexibility, but it also presents challenges, particularly around the healthcare benefits for gig workers. However, certain states have enacted legislation facilitating the creation of portable benefit accounts for independent contractors, including gig workers. These accounts are attached to the individual worker rather than a specific employer, allowing them to pay for various expenses such as health benefits, independent or income replacement insurance, life insurance, and retirement benefits. States who have paved the way include Wisconsin, Tennessee, and Alabama. They've all passed portable benefit reforms in 2025, following Utah's lead, who enacted this in 2023. Governors in Pennsylvania, Georgia, and Maryland have also approved pilot programs to test the model for their states. So that's good news for the gig workers in healthcare, and I think that will actually help benefit the usage of gig workers in our healthcare communities. Now let's look at the on-demand platforms that help hospitals adjust staffing in real time, avoiding the cost of overstaffing and the risk of care gaps caused by understaffing. The platforms that are coming out today are pretty cool. A lot of them have a very user-friendly interface. The technology provides, intuitive both for the healthcare provider and the hospital administrators, simplifying the process. Gig workers are receiving job orders or shifts in real time. And they can communicate through their mobile device. They can accept shifts, they can decline shifts. So it makes it much easier to facilitate the staffing for those critical last minute demand shift openings. The other thing that I think is pretty cool is the AI bots. So a lot of the platforms that we look at have the AI bots where it's really leveraging the technology to address FAQs, things like intake candidate information, automatically creating candidate profiles. A lot, as I mentioned earlier, is helping with the credentialing and onboarding functions rather than having a human having to do all of that manually. I've seen some technology out there where, you can upload your driver's license and it will actually be able to detect whether or not the document is accurate and if it's an actual driver's license versus, a picture of Mickey Mouse or something like that might be uploaded. So there's some real gains on the technology side of the platform. However, you still have to be making sure that the technology there's that oversight that continues to make sure that that is going on. When nurses engage in gig worker through online platforms, the employer of record can vary depending on the platform structure and the worker's classification. Some platforms can partner with EOR services like Adaptive to handle employment-related tasks for their contractors. These EORs manage payroll taxes, benefits, and compliance with labor laws on behalf of the platform or the end client. Some platforms operate as staffing agencies, as I mentioned, directly employing nurses as W-2 employees for temporary assignments. In this case, the staffing agency itself would be the employer of record responsible for all associated employment obligations. So a lot of information and interesting things going on with the the gig worker on that online demand for technology. So now I want to get into the workforce management platforms, which I had mentioned. You know, there's a large adoption. Many large hospitals are utilizing workforce or a managed service program, and in some manner or not. We believe in we believe in vendor neutrality and we believe it's important because it works. Vendor neutrality ensures competition, price competition. All agencies compete on a level playing field, driving better pricing and faster fill times. Transparent, aligned partnerships, that have MSPs operates as an extension to the hospital's team, not the staffing firm with competing priorities. You know, the staffing models is not to decrease your rate, and they're not to decrease your spend, and it's not to decrease your cost savings. In fact, most staffing models, they have to meet a gross margin threshold where they're heavily compensated on not only meeting those thresholds, but also exceeding those thresholds. So that's why we believe that having a vendor neutral platform is very important when you're constructing an MSP model. The other thing I wanted to do is talk about some areas that we are able to do as an MSP that helps our customers to truly save money. And as you can see here, I've actually brought a real life case model. Right now, again, I mentioned the the staffing industry is down. So now is a really good time to negotiate more favorable terms to include volume discounts, to include rebates, and look at better pricing structures. Make sure you're reviewing your contingent labor headcounts and ensuring there's no rogue staffing going on, and making sure that you're working as a collective group to improve any kind of sourcing efficiency, making sure you're reviewing that data on a regular basis. Implement vendor performance matrix to drive better vendor performance, behavior, and quality outcomes. And I'll get into that a little bit more when I go through the lines here of savings. Demand transparency from your MSP. Request specific analytics detailing contract labor spend, utilization. With University of Rochester Medical Center, they give us their budget every year, and we have to come up with a plan collectively on how we're going to get from, how we're going to get them from 148,000 contract labor spend last year to 114 million the next year. And we're held accountable to those metrics. You can reduce costs in multiple ways, through extension reductions, moving long-term agency contractors to an employer of record or a in-house travel pool, or to direct staff. Having a partner that's going to help you convert employees to full-time staff is key. Develop an accountable savings plan that is going to save the hospital, as you can see in these cases, millions of dollars. So I brought this example because, first of all, we're very, very proud of it. And the other thing is, you've seen out there with the big staffing organizations is they just want to hand over, rebates. It's really easy for them. I'll give you 4% rebate, and, here's a check, because they have it in their gross margins, right? We do provide a modest rebate based on volume, but we also want to look at certain characteristics that are going to drive better behaviors from the vendors. And I'm going to walk you through those. So, for example, you can see here the relative savings. Well, what that relative rate savings and why we call it relative rate savings is because it's relative to the market. We don't, nobody here and probably nobody on this call really controls market rates, it's really what the market is going to demand. I mean, we saw a lot going on with COVID, right? So we don't create the markets and the rate. What we do is ensure that our customers aren't overpaying in the market, which is very, very important. So that's why we called it relative, because it's relative whatever the current market is and what the market was previously. So in the first line, you can see the relative savings was 10% in 2025, and I think we had about 14% in 2024, which made up for almost 21 million in contract labor savings. And what that is that's reducing the rate from the prior year. So we had committed that we would do as a team 11.2% reduction. That's what we committed to. And so we came up with a formula that every time we opened up a new order in our system, it was reduced by 11.2% to achieve that goal. The other area of savings is a non-billable orientation, right? And those can vary, again, depending on size and scope and volume, anywhere between 8, I've seen up to 24 hours in non-billable. And that means the first 24 hours, regardless if it's on-site or off-site, is a zero bill rate to the facility. And as you can see, that results in very significant savings. The other is the overtime. So you should never be paying 1.5 on OT for an agency person, because the agency is only paying 1.5 on a pay rate. So there's a big delta there. So we go in and we offer like a 1.2 overtime rate. So that significantly reduces the cost for overtime. Makeup shifts is a very, very important one that we came up with, because it drives, again, better behavior. So, and I'm sure those of you who are working at a hospital, we've got the holidays coming up, and nothing is more irritating to the unit managers than travelers that won't work the holidays. And when you schedule them for the holidays, they just show up and there's no consequences. So we came up with what's called a makeup shift penalty. And that means if that traveler calls out and they have to make up that shift, and they have to make up that shift, by the way, at straight time. They can't charge overtime, any overtime for it. So if they have to work 4 shifts in a week to make up that shift, that 5th shift or that 4th shift becomes a straight bill. There's no overtime in that. It also drives better behavior for the agencies to better control and manage their workforce and their employees that are out working at your facilities. And we've seen a significant drop in people calling out, and we've seen a significant drop in people not showing up to shifts, especially during the holiday times. Extension rate savings is another area where, all of the costs when it comes to contract labor are usually on the front end, right? So if you've got people that are extending and extending and extending, you should be dropping those rates at those extension periods. And that means maybe the agency has to drop their gross margin in order to make that work. And so we have been very successful in negotiating rate reductions. Payroll service, which is employee of record, we've kind of talked about that. Shift penalty savings, right? So if a traveler is scheduled to start an assignment at a hospital and they don't show, there's a 3-shift penalty, which is a credit back to that facility to help them pay for whatever costs they're going to need to cover that shift. But we also take precautions on the front end. So we had built reports inside our technology tools that actually will show what documents have been uploaded. So if you've confirmed a nurse 2-3 weeks ago, and it's a week before that nurse is about to start, and there's no documents in the system, that's a large risk that person is probably going to be a false start. So we share reports with our customers so that we're on a proactive approach to make sure that we eliminate any kind of false starts, which has really helped our facilities, and to help people start on time, and to notify managers well in advance if we feel like somebody is not going to show up. Lastly, I'll talk about conversion savings, and those are huge. With this hospital last year, we had over 44 people convert to full-time staff. Again, we have technology tools where we can look at, hey, this person is getting ready to extend. Let's talk to them about converting to the hospital first before we just go ahead and extend their travel assignment. And if you take a more proactive approach, you're going to see that you're going to get some traction there and you will have a higher conversion rate. And then lastly, I just want to say that, we're very proud of this. As you can see, the year before they were at 148 million in 2024. The year before that was 165. So they went from 165 to 148. Now they projected for 2025. This is their fiscal year runs June through the end of July 1st to the end of June. And so we just completed our 2025 guaranteed savings plan. And this is what our results that we're very, very, very proud of. We outperformed by 7.46% of budget. We came in at 100, they projected or budgeted for 114 million in contract labor spend. We ended up at 105. So we're very, very proud of that. And these are, again, areas where you should be going out to your MSPs if you already have one and trying to figure out where you can yield additional savings. And then lastly, again, back to the poor rural health facilities that just continue to get clobbered out in the market. These are the ones who really can attract the big MSPs and a lot of resources to help them. So there are programs like MSP Flex, which we offer a lot of our customers. We offer this a lot through the hospital associations that we partner with. It's a great opportunity for, rural facilities and small facilities to gain access and have the benefits of a big MSP, but without the, exclusive contract and the tie-ins. So it's a great opportunity to just be able to post a need when you need it and have an access to a lot of facilities or a lot of vetted staffing companies that can fill your needs very quickly. We had a hospital in New York that went through this program. They had a pathologist, out there that they've had open for a couple months. They posted that need. We actually went out and found a agency that specialized in pathologists, and we had the order filled in 2 weeks. So it's a great resource for those facilities to gain additional help, access to a lot of niche vendors, and the support that they need. And then lastly, if anyone wants to download any of our marketing materials, we just came out with a Q2 market rate analysis for 2025. It's got a lot of good information in there regarding some legal updates and things that are going on in our industry as it relates to healthcare. And then you can also look at, what we're seeing as competitive rate structures by region, nationally, and also by specialty. And with that, we can conclude our webinar. And I thank you very much for your time.
Julie, thank you. What a great presentation. And again, if people have questions directly for Julie, please put them in the question box. I do have a couple of questions myself, Julie. I'm certainly not an expert. You're the expert, but how are MSP fees calculated and how do they impact bill rates?
Well, great question. And, it's very important that you're looking at what your MSP is charging. And a lot of times they like to hide the football. So for example, a very large staffing vendor who has MSPs, they go to their client and they say, well, we only charge 3% MSP fee. That helps keep your rates down. And what they're doing, though, is they're charging the facility a $100 bill rate. They're charging their sub-vendors a $90 an hour bill rate, which is a big delta, right? And I've seen it anywhere between 5 to 10 to even in some cases $30 an hour. And and then they take the 3% off the $90 bill rate. So, you have to be careful of those types of scenarios, because if you can get somebody in the marketplace for $90 an hour and your MSP is charging you $100, that's a huge savings for your hospital. The MSP fee, to the second part of your question, Steve, it does impact. So you have to be very careful. I mean, we charge anywhere between 5 to 6%. Right now, the market is yielding anywhere between 6 to 9%. So it will impact your bill rate if you price it too high. It's really a delicate line that you have to manage.
Right. Another question I have, and again, if you have a question, please put it in the question box. But Julie, how do you really go about setting up an employee of record program?
Well, employer of record is very easy to set up. You basically, because the client's in charge. What a lot of clients don't realize is that their HR database is probably a gold mine. There's probably a ton of people in there that have applied for positions where, maybe the med surg is filled today. And if they said, hey, why not join our gig worker pool, or why not join our in-house travel pool? So the employer record is very easily set up. We just became the exclusive employer of record for Vizient. And part of that is, that we can go out and market these services to their members. They're marketing those services to their members to show how easy it is to set up. I mean, it's basically, you send us the candidate and we provide, there's an online tool that we use, but it's very, very easy because the facility is in control of who they want to hire, what they want to pay, and then there's just a markup, and then there's an online technology tool for the processing of their pay and the managing of the activity of their employer of record workers.
Right. You mentioned at the end, and I really liked your vendor neutrality. I think that's so important. But you mentioned in the end some of the things to help areas maybe geographically that are rural, or they have a hard time finding staff. And you touched on it, but just to reemphasize, how do you make sure agencies aren't overcharging, especially in areas like rural areas or where it's hard to find staff?
Well, there's a couple of ways, again, depending on, what the particular situation is. But we know what the market rates are. So if there's any kind of gouging going on in the market, we're going to see it. And also, I think in that vendor neutral model, you are competing. So right now, there's a lot of vendors where there's a lot of overseas recruiting going on, just like back in the IT days. Now it's hitting the healthcare industry, where you're seeing more of the recruiting coming from overseas, where they can significantly lower their gross margins. And a lot of the hospitals, and a lot of the large healthcare firms are actually now utilizing this method because it's, so much more cost effective than paying recruiters $300,000 a year salaries to recruit, right? So that's having a big impact on our bill rates for our customers. And, I had a lot of the large staffing companies like, well, the international, companies are, ruining the market. And why are you working with them? I said, because our customers and any customers are always going to look for the most cost-effective way to fill their positions. And they're recruiting people from the US, and then they're being handed off to an account manager. But it's a much more effective way. And I think that will serve the rural health facilities well as well. When we're working with the system too, Steve, is we also look at travelers that we can move around. So if I've got a traveler in an area, like Arizona is another huge rural area, and if I see somebody coming off assignment at this facility and I want to move them over to this facility, that's huge beneficial to the rural facilities. And it's a great cost savings, and it's a win-win for everybody because the travelers are already in the market. Their credentials have already been, documented and uploaded, and you already have the credentials on the person, and you also know their performance. So that's another way that you can really, when you have more of a bigger view, to really help those facility hospitals and moving staff that are willing to go to those locations that are already in the region.
Right. Well, Julie, I know we're at the top of the hour and there are no other questions pending, but I just want to thank you. What a fantastic presentation. I think Adaptive Workforce Solutions has certainly got some very good benefits from many of the hospitals. And just so people on the webinar know, Chris Wilson is going to share her presentation with each of you. And for the people that registered for the event, and maybe something came up at the last minute and they missed it, but if they're registered, he's going to send out tomorrow a recording of the event. But Julie, I just want to thank you for your expertise and for such an excellent presentation.
Thank you so much, Steve. And if Chris could edit out my, my flubs, I'd appreciate it. Just kidding.
Got it.
All right.
Got it.
Have a great day, everybody. Thank you so much.
Thank you, Julie. Bye-bye. The webinar is now ending.